Welcome to part 2 of this Movement is Life presentation on value in healthcare. Movement is Life is a multidisciplinary coalition seeking to eliminate racial, ethnic, gender, and geographic disparities in muscle and joint health by promoting physical mobility to improve quality of life among women, African Americans, Hispanic Latinas, and women who live in rural communities. Since 2010, Movement is Life has focused on the elimination of musculoskeletal disparities in healthcare. Limited mobility due to joint pain has a dramatic impact on comorbid health conditions, including obesity, type 2 diabetes, and heart disease. The Movement is Life caucus receives financial support from Zimmer Biomet. Movement is Life goals are to raise awareness of the epidemic of limited mobility and develop functional solutions to reduce disparities. Strategize with healthcare providers, community leaders, and other stakeholders to combat disabling joint pain among women, African Americans, and Hispanics. To implement community-based initiatives to combat arthritis and comorbid conditions that lead to immobility. To advocate to decrease musculoskeletal health disparities that contribute to joint pain and immobility, and educate patients on the importance of daily physical activity in decreasing poor joint health and improving overall health. This presentation is driven by the development of the value monograph you see here. This monograph arose from a need to better understand evolving changes in healthcare payment policy. MIL sought to answer the question, is there value in the current healthcare system, and if so, for whom? After 2 years of conceptualizing and debate, a review of the literature, and feedback from patient focus groups, the value monograph was developed and published. The stakeholders who have a vital interest in defining value in healthcare include patients, the providers who serve them, and payers and policymakers who define how providers are paid for their services and care. In general terms, value is often defined as quality divided by cost. Value implies a balance among patient outcomes, the services used to achieve those outcomes, and the cost of those services. When this balance is reached, patients achieve their goals for function and overall health, providers give the most appropriate services efficiently, and the healthcare services provided are cost effective. In our current healthcare system, stakeholder values are not balanced. The cost of healthcare in the United States is not sustainable. Although the United States spends significantly more per person on healthcare than other industrialized nations, our healthcare outcomes are no better and often are worse. Unfortunately, the system is complex, placing the stakeholders at odds. There are various payment models, some more traditional and others more value-based. With all models, there are positive and negative consequences. In the traditional fee-for-service system, a higher level of care needed by complex patients will be paid or reimbursed at a higher rate. A key point is that the provider is sheltered from financial risk. Both factors are seen as pluses for the provider. However, there are several downsides of the fee-for-service payment model. Fee-for-service emphasizes the immediate episode of care and billable services. Preventive care and health promotion are devalued. Likewise, time-consuming services such as education and follow-up are de-emphasized. Overutilization or inappropriate utilization of services may be incentivized. Quantity rather than quality of care is rewarded. Fee-for-service is implicated in the prevalence of low-value care, the use of health services for which the harms or costs outweigh the benefits. Costs are highly variable both for providers and for geographic locations. Now let's take a look at payment models which have emerged as alternatives to the traditional fee-for-service model. Capitation provides a fixed payment over a defined period of time based on the number of members enrolled, per member per month, also called PMPM, regardless of utilization. Bundled or procedure or episode-based payment pays a set fee for multiple services involved in managing a single condition. Value-based purchasing, also called pay for performance or P4P, comprises payment models that attach financial incentives and disincentives, also referred to as carrots and sticks, to provider performance. It ties reimbursement to metric-defined outcomes, proven best practices, and patient satisfaction, aligning payment with predetermined markers for performance, outcomes, value, and quality. Payers may lower global fee-for-service payments and use the savings to reward hospitals based on how well they perform across process, quality, and efficiency measures. Also, hospitals are penalized financially for subpar performance, and the penalties are either translated into direct cost savings for the payers or are used to generate an incentive pool to reward providers who do meet the targets. These principles of value-based care have been proposed by Jane. Value derives from individualized, patient-centered care that is focused on the best health outcomes for individual patients, including the prevention of chronic disease and/or progression of disease. Additionally, payment models should provide incentives for value-focused providers and institutions to care for individuals with complex health problems. Care should be based on common-sense solutions to individuals' health problems, especially when adverse social determinants of health present barriers. In value-based payment models, providers and institutions assess the processes of care and develop decision algorithms for specific conditions. The providers determine what services will be provided for these conditions. This allows comparative cost data across individual providers and locations. Challenges and unintended consequences occur with any payment model, as we've seen in traditional fee-for-service. Value-based models require costly data infrastructure. Processes and incentives are complex, and assigning cost and accountability can be difficult. Decision algorithms can incorporate the biases, either conscious or unconscious, of the people who develop them. Institutional culture and the associated provider behavior may promote provision of low-value care. Reimbursement is not driven by outcomes and may not cover the actual costs of providing care, unintentionally shifting the cost of the rest of the care to providers. In capitation payment systems, the per member per month fees are paid whether care is given or not. This creates an obvious adverse incentive to maximize net income by avoiding or minimizing treatment for patients. These payment models lack consistent risk adjustment for comorbidities, severity of disease, or care for higher risk individual patients. Government programs such as P4P or the Affordable Care Act's Hospital Readmissions Reduction Program have been shown to cause harm and to reduce access for socioeconomically disadvantaged populations while failing to reduce costs or readmissions. Without adequate risk adjustments, providers who treat a larger share of low-income patients will not perform as well on P4P measures. Thus, providers are incentivized to avoid treating them. These alternative payment programs are intended to achieve the policy goals of improved quality and decreased cost of health care. In theory, when costs are contained, it's more likely that all needed services can be funded. However, alternative payment systems have largely failed to address low-value care. These alternative systems have created time and production pressures on individual and institutional providers that may lessen value from the patient's perspective. Access to care is also threatened by some alternative payment system metrics. When providers are unable to meet certain metrics, financial penalties occur in value-based payment systems. Hospitals and providers can have significant difficulty in reaching those performance targets, particularly those who serve socioeconomically disadvantaged populations and patients with chronic comorbid conditions. These patients may have trouble affording prescribed medications, traveling for appointments, or they may lack social support at home. These factors can lead to the patient being labeled non-compliant. Value-based payment systems create an incentive to treat only healthier patients, called cherry picking, and avoid treating more complex patients who will almost certainly incur greater costs for their treatment. This avoidance is called lemon dropping. One example is the so-called hard stop for body mass index greater than 40, which blocks obese patients from obtaining joint replacement surgeries in some centers. To summarize, this phenomenon of cherry picking and lemon dropping leads to provision of care that is determined by the provider aiming for higher incentive payment and reducing financial risk based on the health status of the patient. For the most part, providers, both clinicians and facilities, want to achieve cost containment but not to adversely affect their patients' care. Providers feel that they are the most knowledgeable decision makers and are bound ethically and legally to give the best possible care within accepted standards of practice. Unfortunately, payment systems may impact the ability of the provider to be the decision maker if institutions set parameters for care. Providing quality, appropriate care within a system defined and confined by reimbursement can place stakeholders at odds with providing health. Stakeholders agree that newer value-based payment models should not adversely impact needed care. In order to achieve value, there must be a balance between fiscal concerns and the provision of appropriate care for all persons. In an ideal system, stakeholders are engaged to provide the best care within their community and accepted standards of practice. Payment models need to provide the cost-efficiency structure without adversely impacting needed care. Patients will always expect that the right care will be provided competently, regardless of insurance type and reimbursement model-driven algorithms.